Fantastic. So welcome everyone to meeting 3 of the Provider Reimbursement Technical Advisory Group for the Task Force on Universal Healthcare. My name is Laurel Swerdlow. I am a staff member with OHA helping to staff this tag. Today's agenda, we are going to be covering institutional provider reimbursement models and reviewing some of what we've already discussed with regards to individual reimbursement as well. Dr. Chadwick is our lead. Is there anything else that you would like to add by way of introduction?
No, you were at one point going to discuss the agenda going forward. Are you going to do that at the end?
Yes.
Okay.
This is our agenda for today. We will start by doing somewhat of a quick overview of where the eligibility, affordability, and benefits tag, eligibility, benefits, and affordability tag, where they have been over the past couple sessions, because I heard from you all that it would be helpful to maintain that cross-tag communication. We'll also do a quick overview of where we were at the end of our last meeting. We will then dive into institutional provider reimbursement models. Dr. Chadwick has teed up a similar pros and cons analysis to the one that we walked through last time around. We'll then dig into some capital budget approaches, again, using Dr. Chadwick's pros and cons analysis as a start. We will be able to discuss all of the above and then have some time to walk through our standard wrap-up process. At the end, there will be opportunity for public testimony. I'd like to ask folks on the call, I'd first like to state that this is a public meeting. Folks from the public are welcome to be listening in. I would request that you take your video off and that you mute your microphone for the duration of the meeting. I would like to ask at this juncture if there is anyone here to testify, to provide oral testimony, if you could please unmute your mic and say so at this time.
Yes, Mike Huntington.
Fantastic. Mike, we will make sure, so at 10 till 1, we will wrap up and hand over the mic to you for that testimony.
This is Charlie Swanson. I may want to say something, depends on what happens in the meeting.
Sounds good. So I have Mike, and I apologize, what was the other person? Was it Charlie?
Charlie, yes,
yeah,
thanks.
Yeah. Anyone else? Okay. So a quick reminder of where we were at the end of our last meeting. I did send out that meeting summary that will be included for the full task force meeting materials in next week at next week's meeting. We discussed that we will likely want to develop a proposal that incorporates a mix of individual provider reimbursement models to account for differing needs of providers. We are envisioning a matrix that gives model recommendations for provider types. I also heard from you all that there was a need for clarity on the process for drafting the policy proposals and clarity on the level of detail that should go into them. Additionally, we heard from you that it's hard to say how providers should be paid if we don't know yet what services those providers will be providing. Related to that, as I mentioned earlier, we heard that there was a desire for more cross-tag communication, specifically with the eligibility, benefits, and affordability tag, which is currently underway. We're going to dive into that in just a second. Lastly, we mentioned that we'd like to bring in potentially some stakeholders that are engaged in this work. We'd like to wait until we really have something for them to react to. I'll pause here. Is there anything else that came out of our last meeting that folks want to make sure is captured in this summary? There is that full summary, but these were the bullet points in that report back section. Thumbs up? Cool. So one of the main questions that we really were grappling with last time around was the process for drafting the policy proposal. The project team really sat down and tried to think through what the best process is for that. We think it might differ from tag to tag. Generally, though, we feel like the tag needs something to be reacting to. And so there needs to be some development of a straw proposal that the tag can then review, discuss, edit, possibly incorporate dissenting voices to outline any possible range of opinions on the proposal, and then bring those key themes from that policy proposal discussion to the tag for to the task force for decision making. This was the general process that we talked through. Does this feel like a process that makes sense to you all? Do you feel like it would be best? I heard from you last time that it would be helpful to have something to be reacting to. Yes, Deborah.
Yeah, I think it's a good process. And I would also like to have sort of the context for the decision points you draft in the proposal. Like how you got to the things that you've incorporated.
Okay, yes, that makes sense. For this one, I was going to offer to take a stab at drafting that straw proposal. Are there any tag members that would like to take that on? Okay, feel free to reach out to me if that changes. We'll talk a little bit about next meetings and how that will be presented. Dr. Chadwick.
Yes, I was just going to suggest that we maybe just revisit this for a moment at the end of the meeting after we've had today's discussion as well.
That makes sense. So in terms of the level of detail, that's a question that a lot of the other tags are having. One thing that we are developing, is an attempt at a matrix that outlines the various design elements. We are still modifying this slightly in advance of next week's task force meeting. So this document will be presented at next week's task force meeting, but I wanted to let you folks know that this is coming down the pike, and that that you're not alone in grappling with this question of the level of detail. And so we're doing our best to create a tool that can kind of help enumerate the decision points and the level of detail that we need. Filling out this, it was discussed at yesterday's EBA tag that filling out this matrix is not itself the deliverable, but it is a tool that can help guide the drafting of the final report that will be brought back to the legislature. So, as I mentioned, the EBA tag did meet yesterday. It additionally met 2 weeks prior to that. So this is a summary of the meeting that occurred 2 weeks prior. It occurred the day before our last meeting, but we offered a summary verbally at last meeting. I wanted to offer this slide here that is the report back from their meeting too. They are really discussing the concept of wanting this plan to embrace a value of nobody out, everybody in. They're talking through thinking through how to grapple with possible instances of dual eligibility. That's a big concept that they're grappling with. And that conversation was really, really led to yesterday's conversation that they had, where they tried to get a little bit more specific on guiding principles and values related to coverage. Again, they were really clear that they are envisioning a plan in which everyone in Oregon gets covered. They are envisioning that visitors would get covered to a certain extent. They'd ideally not like to have to put any duration around residency. And ideally, they're hoping to wrap in Medicaid and Medicare into this plan, acknowledging, however, that there may be barriers to that. And so they stated that they would like to pursue that option until it is no longer viable. They are hoping to be decoupling insurance from employment in this plan. And then lastly, they are envisioning a plan that allows simple and easy enrollment. All of this will be discussed in greater detail at the upcoming task force meeting, which is happening next Thursday. We'll get to that in a second. but I wanted to offer you just this summary because, again, we heard that there was a desire for more cross communication. I was hoping Xenia might be able to chime in here because she is the member that is on both the eligibility, benefits, and affordability tag and this tag. Unfortunately, she's not able to make it today. I can do my best to answer any questions. Do folks on this tag have any questions about the conversation that happened yesterday?
I have a quick, oh, go ahead, Dwight.
Oh, I was just responding to the talk about visitors getting covered to a certain extent. What was their thinking around what does a certain extent mean?
My sense is that there is still questions around certain extent what that means. My sense from the conversation is that they acknowledge that it might not be possible to offer the full range of benefits to visitors, but that they would like to be able to have some type of, be it emergency coverage or some type of more limited scope of services that may be offered to visitors.
And that makes sense. That's what I was wondering, if it was primarily emergency treatment, because otherwise you'd have people vacationing to get medical treatment that they couldn't get elsewhere. And I think that's the approach a lot of New Zealand takes, that approach in their healthcare system for visitors. If you're injured in New Zealand, you can get treatment. If it's not an injury, it's a pre-existing condition, and then you pay for that as a visitor. So that makes sense.
And Dwight, I think that that's an excellent comment and statement that you may want to voice again at the full task force meeting when this comes up.
Okay. The other question I had, did they have a conversation, and this may be a better asked at the full task force meeting, but when you think about some of the OEB-PEB retirees that might be living out of state and but still covered in the Oregon system, did they have conversation about that?
It's a great question. They did not, to the best of my recollection, they did not specifically call out PEB OEB enrollees. Sarah Nipper is on the call, and she is the lead staff member for that. So Sarah, please interrupt me if I'm misconstruing the conversation here. They did, however, discuss whether or not folks who are outside of the state, for example, they discussed if there are folks who get insurance through their employer and the employer is based in Oregon, but they physically reside in another state, whether or not whether or not those folks should be allowed access to this plan. Sarah, my sense was that conversation did not land and that there wasn't clarity on that. Please let me know if you feel like that's if I'm misconstruing that conversation.
No, I think that's accurate. My sense is that the number of folks we have who work out of state, not in a border state, and are employed with Oregon companies is actually really fairly small from some data that I've looked at. So we did talk about out-of-state folks. The retirees, OEB and PEB retirees, that's a really great point. We did not get that detailed, but that is a great point that I'm adding to my list to make sure that we look into.
Thanks.
Any other comments?
Cheryl has a question. Cheryl, you might, yeah.
Hi. Could you clarify in the second bullet other public programs, and specifically, does this include programs that are mostly funded through state general fund and some county general fund, federal block grants, that type of thing? Which is a lot the programs that I represent. So I'm curious.
Yeah, the concept yesterday, as I understood it, is that the tag is envisioning a singular plan that encapsulates all services, that is the ideal. And so while they didn't call out those types of block grants, those types of safety net programs, my sense would be that the tag would respond by saying they would, in an ideal world, want a plan that encapsulates those safety net dollars, encapsulate those services, and encapsulates these, broader publicly funded programs like Medicaid and Medicare. Again, they acknowledge that that might not be a viable option, and so they would like to. It was stated that they would like to shoot for the moon as much as possible, acknowledging that ultimately this type of program that wraps everything in might not be viable, and they may need to turn to alternate structures.
Okay, thanks.
I just want to maybe clarify a little bit, though, that when we're talking about all other public programs, we are not talking about other public programs that fund like an array of services or that fund other things. We are talking about other public and other public coverages is really what we're talking about. So if you are receiving your coverage through the VA, TRICARE or Medicare or OHP, we did not discuss, and I don't think that this is the intent of the tag, sort of wrapping in every public program that funds maybe like a certain array of services. Those services may be included, but what we were really talking about here is we have these big buckets of coverage with different funding sources. The idea, the intent that the tag is really aligning with is that, for example, a lot of states have excluded Medicare from their plans because there's no like Medicare waiver program in the same way or option in the same way there is a Medicaid waiver. In this full enrollment option, we would basically ground break the idea of a Medicare waiver so that Medicare and OHP and potentially the VA services are wrapped into this plan.
Nipper, did we lose you there?
Uh-oh, can you not hear me?
Yeah, we can hear you.
Yeah, we heard most.
Okay, sorry. I'm done.
To
Dr. Chadwick.
follow, I have sort of two tiers. To follow up on the comment regarding things like the VA and those things, I don't know. It seems like a reach that we're going to, take an effect to defund the VA hospitals, which get their funding through another stream. But if that was the thread that they're going for in this sort of theory of reaching for the moon, I understand it. And then the other question I have about that is Department of Corrections and whether it was the intent to exclude Department of Corrections healthcare or to include it. And then just to get my other question out there as well, I noticed that it says everybody in or gets covered. And that probably relates to the thing that you sort of alluded to, Sarah, regarding Medicare and a Medicare waiver, because it's all well and good to try to get a Medicare waiver. But that's, I think everybody would admit that's a heavy lift. And it sounds like that the eligibility benefits and affordability tag at least acknowledge the possibility that this morphs a little bit into a universal care plan as opposed to a true single payer plan.
Yeah.
I'd like to offer clarity that it should read everybody in Oregon gets covered.
Oh, that's in Oregon. Oh, I see. Because
I realize now that we should have spelled it out.
Yeah, I read it as everybody in or gets covered. Okay, so they have not sort of come to any conclusion regarding Medicare, except for to try to do the heavy lift.
That is
That's
true.
right. And I do want to just say, because we have so much to cover today on the rest of our agenda, I do want to make sure that we are kind of flagging what the conversation is with the intention of bringing it back to the full task force. I just want to acknowledge that we're trying to grapple with how we share information, but make sure that we keep moving forward. Nipper, I would like to give you any final thoughts on this.
Yeah, I just want to address one thing that you said, Dr. Chadwick, which is I think there is general agreement that we would not be turning down or trying to replace like Medicare dollars or VA dollars. So when I'm talking about wrapping things in, we're talking about finding a way not to take advantage of all of the federal dollars that are still coming into the system, but sort of wrapping it into a plan that would maybe change some of the requirements, but certainly not try and come up with the dollars to replace VA services or Medicare funded services.
Right, I understand. It's just that those things are they're whole sort of enclosed systems, corrections, and also VA and those things. And okay, enough said on that.
So I do want to acknowledge that the main place that this tag interacts with, the eligibility, affordability, and benefits tag interacts with the provider reimbursement tag in several ways. One of the more robust ways is their decision-making around, or their recommendations around benefits. I wanted to flag that the last two meetings, they've been focusing on eligibility and enrollment. The next concept that they're looking to tackle is the question of benefits. And I've made sure to be communicating that this tag, that we heard from this tag last time around, that in order to figure out exactly what the reimbursement model should be, we need a better sense of what services are going to be covered. So I wanted to flag for you that is the next conversation that tag is planning to take on. So there are lots of meetings in December that I wanted to flag for you all, so that you have a sense of where we're headed. Yesterday there was the eligibility tag meeting, the provider tag meeting, obviously happening right now. And then next week we have the full task force, followed in the subsequent week with the CAC, and then the finance and revenue is having their second meeting that week as well. And of course we have our fourth and final meeting for 2020 coming up on the 18th. So be nice to staff, there's a lot going on. Okay, we're ready to dig into the meat of this conversation. I want to remind us all that 770 defines provider as an individual, institutional, or a group practice, individual provider, institutional provider, or a group practice. Last meeting, we dug into individual provider reimbursement methods. Today, we're going to be talking about institutional provider reimbursement. The bill defines an institutional provider as a single legal entity that is a healthcare facility, comprehensive outpatient rehab facility, home health agency, and or hospice program. So this includes short-term acute care, it includes transitional care, and it includes long-term care. Within the realm of short-term acute care, we are talking about hospitals. We're talking about both private and public hospitals. Private hospitals are structured in a few different ways. We have research, non-research, and it's important to call out that rural private hospitals have their own elements that they are thinking through that may differ from metropolitan hospitals. Public hospitals may include the county hospitals, VA, military hospitals. In the realm of transitional care, Dr. Chadwick helped enumerate a list of the various possible types of transitional care facilities: wound care, diabetes management. Again, like with in the individual provider presentation, I want to flag that this list is by no means exhaustive, but is intended to highlight the range of care that may be provided at transitional care facilities.
And the range of things that may need to be thought through in reimbursement. Because it could be that the approaches to reimbursement are different. That's the reason I listed them, is so people can think about approaches to reimbursement.
Thank you. Critical concept there. In the realm of long-term care, this may include nursing facilities, ventilator-dependent facilities or care, correctional facilities. Behavioral health may fall into this category as well. I want to flag that as a reminder, behavioral health is on this list of providers who may require unique consideration. So again, they fall into this category of we want to make sure we're constantly thinking about how behavioral health and the rest of these providers listed here may require unique consideration. Yeah, Cheryl.
I just have a question to clarify institutional providers. In the behavioral health system, there's a very specific meaning about institutions, and so I'm having trouble kind of understanding how these various providers fit into institutions. And so for us, it's the Oregon State Hospital is an institution, the prison system, the Department of Corrections institution. It's mostly like a large locked facility. So I'm not quite sure I understand the definition of institutional providers here and in how behavioral health fits in. I'm not understanding this, so.
Can I take a stab at it, Laurel? Cheryl, I understand your sort of question about it. A couple of comments. One is that the legislation uses the term institutional, so it sort of bifurcates this notion of institutions. And in their case, they weren't thinking about behavioral health. They were thinking about, large organizations that receive funding maybe in block. So that's one thing. So I think the onus is upon us to further sort of parse this out a little bit to make sure that that we don't get ourselves confused in terms of what institutions are and what they aren't. I just threw some things out here in this category because some of them could fall into the notion of institution and could not. I think it's a bit of an artificial divide, frankly, as you're pointing out. And we just need to be cognizant of it as we move forward.
I also think within the conversation of reimbursement models, at a very basic level, there's the question of, is the money going to a singular individual provider, or is the money going to a broad system? And and the bill really tries to flesh out that the way money flows, it tries to suggest that the way money flows to an individual provider, we may want a plan that offers a different system of that money flowing to broader systems, to single legal entities that are overseeing several providers. Have we helped kind of start to piece that?
I think I understand how you're defining institutions. It's just very different from how we use the institution in the behavioral system, or I would say in the DD system as well. So.
And Dr. Chadwick did highlight that this is the definition that the bill offers. This first bullet point here is the definition that the bill offers. I think we have an opportunity to augment, modify, offer our own definition. So I think, as we've said throughout this process, Cheryl, I think we are really going to want to be highlighting the ways that the behavioral health system is unique in this regard.
Right, and Cheryl, maybe to use your example. Sorry.
No, please.
Maybe to use your example, in your terms, sort of institutional, it could be that the providers that are being reimbursed are individual providers because they're providing individual services to patients that find themselves in those types of quote unquote institutions. So, you know, I think that that's where we have to really break it out and make sure. That's why it's valuable to have you and Dwight on this group, so we make sure that we're cognizant of what we're talking about.
Okay, yeah, I'm just going to have to get used to that different way of looking at institutions. As you know, we were created out of deinstitutionalization from the Community Health Act. So we are like the opposite of institutions.
Right. So I think,
And,
but I think that
in
what
this
they're
frame,
talking about.
in this frame, we would be considered an institution per your definition, because the way the money flows is to a particular entity, and the individuals are paid, you know, salaries. And so
Right.
yeah, so I just have to get my head around that.
Right. I think that the underlying issue is that as Laurel pointed out, that the reason they sort of broke it up that way is that organizations, whether they be, you know, behavioral health hospitals or acute care hospitals, organizations can be reimbursed in a manner that isn't suitable for individuals. And so I think that's the way that's the reason that they sort of broke it up that way.
Dwight.
Thank you.
And I think following up on Cheryl's point, I think it's important that we stay aware of the fact that there's different types of behavioral health care providers, because when we talk about the model Cheryl's referring to, we're talking about community behavioral health programs that generally are the county-based systems that receive state general fund payments for indigent care, as well as a lot of other evidence-based programs and so forth. And then you have private providers, psychiatrists, licensed clinical social workers that don't work under that system, that are working individually in the community. And I think that the challenge we're going to have is how do we fund both systems so that we don't lose what we have in the community-based system that is really focused a lot on population-based care, as opposed to providing single point of care for an individual that you would see in a private provider.
And then that is sort of a circular equation back to the other tag a little bit in terms of what it tries to subsume into this and what it is unable, if you will, to bring into it, in which case we have to tailor it a little differently, because it could be that some of those things that you're referring to, Dwight, really at the end of the day will not be rolled into for whatever reason, legislative or regulatory or whatever.
Did we lose Deborah?
Thing,
I just realized I can't see Deborah. I wanted to check in. Okay. Please, Dr.
One other
Travis,
thing I just wanted to refer to, and that's when we're talking about long-term care, we've had robust discussion at the task force level about long-term care. We're not through with that discussion. It was just my intent to put the array of institutions here so that this group could at least conceptualize that there are all of these kinds of facilities that are, if you will, buildings full of patients, if you will, to use the broad term of the notion of institution.
And on that note, this is another, again, list of possible organizations, types of entities that may fall under this umbrella.
Right, and these are going to be critical questions that are going to have to get resolved. Some of them are easier than others, but I think that, you know, in the case of the tribal services, it could be that it's going to have to be thought through in terms of what's culturally appropriate and correct for services into the tribal organizations. And the other thing is things like integrated care organizations like Kaiser. That's really a bird of a different feather, and it probably will lend itself to being fully capitated but it's definitely, because it not only does it have individual providers, but it has institutional providers all under one umbrella.
It's an excellent segue to just a reminder of what your reference to capitation and the various models. This is a reminder of what Senate Bill 770 says with regards to institutional providers and capital budgets. I want to highlight that it does say, or using an alternative method here. So it does provide the flexibility for the task force to recommend models that may differ from what is outlined here. It does say in the bill that institutional providers shall be paid with global budgets that include separate capital budgets determined through their regional planning and operational budgets. It indicates that budgets shall be determined for individual hospitals and not for entities that own multiple hospitals. So we've defined, generally speaking, what the range of what an institutional provider could look like. Speaking now about payment models. We saw this slide last time. I wanted to remind us all that generally speaking, payment models can be divided into two broad categories: fee for service, which is the traditional payment of a specific dollar for a specific service, and alternative payment methodologies, which is a term that broadly captures all non-fee-for-service payments and intends to incentivize quality over quantity and, generally speaking, improve health outcomes. I walked through line by line this slide last time around. I wanted to integrate it into this presentation as well as a brief reminder of how the congressional of the menu of models that the Congressional Budget Office presents in the paper, recommending single payer questions that states may want to consider. We talked through many of these last time around. Some of them, like global budgets, capitated payments, even salaried providers, as Dr. Chadwick was just referencing in the context of integrated care, all of those lend themselves perhaps more appropriately to institutional providers. So we'll hone in on those this time around. And we've now arrived at the pros and cons analysis. As a quick reminder, this is Dr. Chadwick's attempt to, well, Dr. Chadwick, why don't I just kick it over to you and you can define what this is. You know, you're on mute.
Thank you.
Yes.
What I said is this is my 2 cents worth, and that's really all it is. And I would recommend, I think that the CBO article is an important document for a couple of reasons. One is it gives a little shade on what the feds are thinking about vis-a-vis single payer. And it also is a very good and pretty concise analysis of the merits of various reimbursement methodologies. So I might recommend, if you haven't had a chance to take a look at it, you might take it out and put it under your pillow. Okay, so again, we'll go through, let me make sure I got the right place. We'll start with global budgets. And so I think for this discussion, just for purposes of simplicity, think about a hospital. Think about your local hospital, and just for sort of to narrow it down, that will help you in terms of thinking about this. What the legislation says is that they really call out a global budget. As opposed to any of the alternative methodologies, either that are used now or could be proposed in the future. or something else that we and the task force might recommend as an alternative to a global budget. So I just kind of want to illuminate that. So when we're talking about the pros and cons of these various things, including the global budget, you will keep that in mind. And then per diem. Per diem, it's a payment per day. Think of it like a hotel room rate. It is paid to hospitals typically on 3 tiers. Which is a med-surg room, standard med-surg room, usually a step-down telemetry or subacute, not subacute, but telemetry or monitored room, and which is kind of in between an ICU and med-surg, and then at the highest level ICU. So typically per diem rates that are negotiated between insurance organizations and hospitals are paid on a 3-tier per diem rate. And basically the idea is very simple. People come in, they're in one kind of a room, and then they move to another kind of a room, and then they move to another kind of a room. The bill goes out on that basis, and the organization is paid on that basis. Fee for service is what it sounds like. It's a fee schedule, in the case of hospitals, a thick document about this thick that is a fee schedule down to the gnat's eyebrow. And if any of you have had hospital care, your parents have had hospital care, you've looked at that bill. That's what the fee schedule is. It can go all the way down. We always hear the story of toilet paper, or we hear the story of a paper cup or whatever it might be. Fee schedules are fairly standardized in the industry these days, but they are not entirely standardized. And furthermore, the fees themselves that are put out there are definitely not standardized. So for example, where I live in Central Oregon, St. Charles has a fee schedule that may be different than Providence or than another hospital organization elsewhere. So it's a very, very specific fee that is established, and it's additive. Cost base is really the idea. It's just what it sounds. You submit to somebody your costs, and you're compensated for your costs. There are certain types of organizations that are cost-based. All of them are a little bit, but that's the notion of that. So we'll come back to sort of what incentives that creates. Capitation is per head. It's per enrollee in the population. So for example, a family of 3 would have a capitation per member per month. There would be 3 members, and it's basically whatever the negotiated per member per month reimbursement is. That's the way the organizations are paid. Case rates, go back a little bit, don't change quite yet. Case rates are quite important for us to understand because they form the basis for institutional reimbursement in the case of Medicare. That is, Medicare had a huge cost inflation problem about 35 years ago or so, and it could not retain paying on a fee for service anymore. They established a new approach, which is on a case rate. So they took all of the potential diagnoses in the world, basically, and they put them on a schedule, and they said to hospitals, we're going to pay you based on the diagnosis, not on the basis of what you do to the patient. And then it's on you to figure out how to deliver the care within the context of the reimbursement for that particular case rate. And then bundled payments are an approach which actually can include hospitals and doctors and medical groups into payments that sort of say, well, it's not just the hospital and it's not just the doctor, but it's actually the interplay between the doctors and the hospitals. So we want to create an incentive for that interplay to be efficient. So let's establish bundled payments, and we'll pay the hospital for physician services as well, and then it's up to the hospital and the physicians to work out who gets paid what for what. Next slide. So just a couple other things to bring to your attention. One is research organizations Oregon Health Sciences, for example, they have a different mission. They deliver acute care, but they also deliver research, and they have a lot of other costs associated with conducting that research, and their reimbursement has to take into consideration, or right now does take into consideration, in the case at least of Medicare, that there are costs in excess of a normal acute care hospital for conducting that research. So we're just going to kind of keep that in the back of our mind, because for academic organizations, they have residents and other people who are going through the organization that elevate the costs of delivering care. For rural and other population, as I mentioned, the tribal areas, they have other problems. They have recruitment problems. They have other care delivery problems. And so the way that organizations approach reimbursement for rural organizations may be different than it is in an urban setting, Portland compared to Pendleton, for example, or even more remote than that, Lakeside or some other area that has a small acute care hospital. Those small hospitals might be 30 or 40 beds compared to something that may be 300 or 400 beds in an urban area. And then the last thing to keep in our mind is the role of recruitment. We'll come back to it later, but recruitment can be a real challenge. And if it's the intent of this whole strategy that we're about to ensure that access to care is uniform across the state, then we have to consider the role of recruitment, particularly in areas that are typically hard to recruit. And that can include rural areas and the tribes. And maybe also other sectors that are typically hard to recruit. I can't speak to behavioral health or other things that may have recruitment challenges as well, which cut another direction. Any comments on any of that? Okay. So then I'll just go through the pros and cons as I think about them for a global budget and the other payment approaches. So a global budget is very predictable, right? You're going to do a standard amount of money. You're going to pay them the money maybe up front at the beginning of the year. And then it's on the hospital to deliver all the care to everybody that comes in the door, no matter what happens to them, and with the dollars that they have. This is something that's very commonly used in other countries. It's used in Canada, it's used in the UK. It's a very common approach. I think it's probably the reason that the bill proposed this idea. And of course, it has little or no admin costs because you don't have to have bills or you don't generate anything. They just get the money and they deliver the care. The problem with it is that it really does not consider variation in patients. It doesn't consider variation in patient acuity, who's more seriously ill or not, doesn't take into consideration whether we have fewer patients or more patients, and it doesn't take into consideration things, unexpected events. We're living through an unexpected event right now, and right now, if hospitals were on a flat budget and there was nothing done about it, then that would create a huge financial problem for those organizations. So it may, in the end, overpay or underpay for an individual hospital. There can be this notion of care diminishment, or what I call thinning the soup. So the idea is that you're short on money, and as a result of being short on money, you cut corners. And in healthcare, hospitals, and really throughout healthcare, it's very easy to do that if you're so motivated. It's very easy to do things to advantage yourself or keep yourself alive if you don't have the money. And so there is this care diminishment problem that needs to get thought through if we go forward with a global budget. There are approaches around it. You can create a boundary and say, if they exceed this boundary, we're going to look at it or something. But I just wanted to bring that to your attention. And lastly, there can be no incentive for efficiency. In fact, the history shows us in a lot of countries, there's an incentive for inefficiency. because typically budgets are sort of based on last year's budget, if you will. And we've all dealt with this in various entities where there's a motivation to spend in order to keep the budget up where it needs to be in order to get next year's budget where you think it needs to be. So there are some issues around budget. You can strategize and you can create ways to counter them, but I did want to bring that to attention. The last one is the reduced capitalization. I'll talk about capital separately, but the notion of capital is the money that you use for an MRI machine, you use for new hospital beds, you use to repair the roof. There's an enormous amount of capital that goes into institutions and keeping them going. If you don't have money and you're delivering the money for institutional, you're delivering it for patient care, you may not have money left over for capitalization. And that is certainly true in the UK right now. If you go to hospitals in the UK, what you find is they're very undercapitalized right now. Not all of them, but a great many of them are extremely under-resourced. And as a result, the facilities that they have are not the way you and I might expect them to be. Next slide. Per diem. I mentioned this before. This is you paid on a daily rate. I don't need to go through that again. It's a fairly modest admin burden. The payer really needs to add up the days on med-surg, the days in telemetry, and the days in ICU, pay them on the negotiated rate, and that's the end of that. So it's a fairly low admin cost compared to a fee-for-service. Per diem, unfortunately, doesn't fully consider patient acuity. It does a little bit because if you're in an ICU, they'll pay more than if you're on med-surg. But there are elements of patient acuity. You can have very acute patients getting a lot of resources on a daily basis that are not in ICU, and it doesn't always consider that. Again, it may overpay or underpay depending on what the rate that is paid and what your patient care experience is. There is the same problem of not having enough resources for capital or sort of diluting the soup. It's a bit of a problem, not as much right now, but to the extent that we move to the point where the state is establishing the payment and the payment is inadequate, then we can run into that kind of problem. There may or may not be an incentive for an efficiency. It depends. And these other points are the same thing. The implementation issue is that if right now organizations are not used to being compensated on a per diem basis, then it can be a transition that takes some adaptation to get used to. Yes.
Is the prospective payment system considered a per diem in this case? I'm kind of wondering if the prospective payment system payments, where there's a wrap payment for like an FQHC or in the behavioral health system, the certified community behavioral health centers, would that be this type of payment?
Actually, prospective payment can be a variety of things. In the case of hospitals, it can be DRGs, case rates, where they pay prospectively based on the case rates. Prospective is a little bit of a misnomer. In the case of FQHC, it's typically cost-based. Those organizations are cost-based, submit kind of a cost report at the end, and you get reimbursed on costs. So I would say none of those prospective payment has really steered away from per diem.
Okay.
Fee for service, I think we all know what that is. It's open-ended. I send the bill and you pay the bill. I'll give you an interesting history, very brief. When Medicare was first negotiated in 1965, it was very, very, very heavily opposed by the American Medical Association. And the AMA said, over our dead body, socialized medicine, we're not going down that road, no way, no way. And the way that got resolved is the government said, well, what if we pay open-ended fee for service? Would that be okay? And the AMA's resistance to it disappeared in New York second. And so then for the next 15 years or so, everybody sent bills to Medicare. They paid the bills. It was very inflationary. So it does create, and that's the reason eventually it went to prospective payment, because it was really breaking the bank. And so by 1980, they had to go to another plan because there's no way they could reimburse on a fee for service, because it was just created an incentive to just do more. And if you look, interestingly enough, if you look at the length of stay by a Medicare patient in, say, 1970, and you look at the lengths of stay in a Medicare patient in 1990 or 1995, when they went away from fee for service, you'll find the length of stay is roughly half, maybe even less than half. And that's the reason there was no incentive to reduce length of stay. You send the bill, they pay the bill, America's great. So fee for service is what everybody's trying to move away from. It's not oriented to value or outcomes. There's no incentives for efficiency. The fee schedule is enormously arcane, so we have all these thousands and thousands of billers sending bills out, and really it's not sustainable. Next slide. Cost base we've talked about as well. It is the notion that whatever your costs are, we will reimburse. FQHCs are cost-based programs. That's the reason they're able to stay alive, if you will, as long as it's cost-based. You submit your cost reports and you get reimbursed for your cost reports. I think that may be true, Cheryl, in the case of these prospective behavioral programs too. I have an idea they may be cost-based, but I'm not sure.
Yeah, they're the same. They're PPS too.
Yeah. So cost base is protective and ensures providers have sufficient resources. It can be inflationary, because if you're raising your costs and you're getting paid for your costs, obviously there's an incentive to consume. Again, not oriented toward value. There's no incentive for efficiency at all. And it creates a large overhead because you do these huge cost reports. It's a whole staff, a whole sort of tier of work associated with building these reports, both on the provider side and also on the government side, to go through these cost reports and audit them and so on and so forth. Next slide. Capitation, I think we've talked about. Capitation is per person per month coverage. It is very simple to administer. You just basically count up the people and you pay based on that amount per month. It is very easy to administer in rural areas. There's typically one hospital. You could capitate a hospital in a rural area. It's a problem in an urban area because there are a lot of different hospitals. And one of the themes of this whole initiative that we're talking about is patient choice. So it's very hard to imagine how you could capitate urban hospitals because they're tied to a particular patient. And if you want to allow patient choice, you simply can't capitate in an urban area, because I may want to have a choice between Providence and, OHSU or something like that. So it creates a real challenge. It does have an incentive to reduce care, right? You're getting paid up front. So then you could theoretically have an incentive to reduce care. There are a lot of people that are concerned about the incentives that are in capitation to reduce care. It could be unnecessary care, but theoretically it could also be necessary care, right? It's very hard to, they don't need that test, or they don't need whatever. I've got my money already, so now I'm motivated to reduce the amount of costs that I have to incur on your behalf. It can also create predictability, so it's very predictable, and government and payers like the predictability. I mentioned the incentive to minimize care doesn't work in urban areas, as I mentioned. And again, it's not oriented inherently, it's not oriented to value or outcomes. Now, you can attach value thresholds to it. So you could say, for example, well, we're going to capitate you this amount, but then we're going to tie to that certain performance indicators that then move it over into a value-based approach. So it's not that capitation is not oriented toward value. It isn't by itself, but it's very easy then to attach certain outcomes that you're looking for in order to induce that behavior. And then, of course, choice for patients is a huge problem in urban areas. Next slide. DRGs I've talked about. it does take acuity into account because, you know, if you're going to go in there for heart replacement surgery, if they still do that, then that's a certain resources that are tied to that, and the organization gets paid more. If you're going in there for an appendectomy, it'll be different again. So it does take acuity into account. And there are ways to that in the DRGs that they have little modifiers to the DRGs, so that if you have certain comorbidities and that kind of a thing, you can add modifiers to it, and it raises the amount that an organization is reimbursed. It's relatively comparable between hospitals. You can look at the data. You can compare the data between hospitals. Cost structure is quite manageable. I mentioned this about Medicare because Medicare pays on this basis. So organizations throughout the state are very familiar with this sort of case rate reimbursement approach. It happens to work well in urban areas and rural areas. So, so that's quite easy from that standpoint. Surgeons, procedurists are not included. So it's just facility care, and then there's a separate payment approach for the procedurist. You go in for an appendectomy. You and I know this. We get a hospital bill, but then we get an anesthesia bill, and then we get a surgeon bill, and then we get a radiology bill. We get all these bills on top of it, and the reason for that is because they're not included. Those are maybe paid on a fee-for-service basis or some other approach. And I think that's the reason that this whole legislation sort of bifurcated between institutions and individuals. There is an incentive to reduce length of stay to some extent, but you can protect for that. And they do in the case of Medicare. If you're readmitted within a certain period of time, it's not paid. For example, if you're in the hospital, you have an appendectomy, you go home, you get an infection, and you come back in 3 days or something like that, that second stay isn't paid at all. So there's some ways that you can protect for unreasonable early discharge. Again, these are really payment methodologies that talk about the flow through. They're not really oriented to outcomes per se. They're really oriented to kind of more or less to resource consumption. And then administrative burden is still fairly large because they have these things in hospitals called coders. And there's a lot of these people, and what they have to do is take what happens. They're sort of translators, if you will. They take what happens in the hospital and they sort of place codes on them so that they can bill out accordance with the DRGs. Any questions? I'm racing through this fast because I'm already over time. I know that, Laurel. Bundled care, next slide.
I want to highlight that we added in those slides at the beginning to offer the summary of EBA, so you should be over time. You're doing more. Yeah,
all right.
You're doing the right thing. You're right on time.
I'm not going to get demerits here. Okay. So bundled care does more take acuity into account. And it is more comparable. The main notion of bundled care is that you're paying, so I'll use my example of an appendectomy. So you're going to pay a set amount for the hospital costs and the hospital reimbursement and the surgeon and the anesthesiologist. And sort of everybody associated with that. You're going to pay one thing for this notion of a bundle, because every time you get an appendectomy, you're going to need all those things. So the payer then feels like what they want to do is not get milked by all the individuals, but they want to pay a set rate in a bundled manner and let the hospitals and the doctors carve it up, and it doesn't become a financial burden on the payer. And I don't know if we're going to discuss, Laurel, the little chart I did, but if you look at that little chart that I think went out in an email, what you'll notice is that it sort of takes a look at that in terms of what the risk is for bundled care. Next slide. Am I done? Okay, so I'll just keep.
Yeah, great. Let's keep going.
Okay. Capital budget. Now, I'm going to just define it briefly for those people that may not be financial geeks. And for those of you that are steeped in finance, please bear with me. We just want to make sure everybody understands what the notion of capital is. What capital is dollars. It's an accounting term. These are dollars that are associated with large expenditures, capital expenditures, typically over $500 or over $1,000. In that case, you can what we call capitalize it. So you can amortize it over and depreciate over a long period of time. And it is where the money comes from for the building, for the equipment, for the air conditioning, for everything that is not really associated with the operation, but the operation depends on. So for hospitals, even the smallest hospitals, they will spend $2, $3, $4 million on capital. A large hospital, a large organization might spend $100 million on capital. You'd be surprised how much money it takes to keep these large facilities going. And our expectations for the most current MRI, most current CT, the most current diagnostic things our appetite is insatiable. So that's the notion of capital. And the legislation carved capital. So it basically, the way I read it is that it wants to reimburse organizations, institutions for their patient experience on one way, and then they want to consider an alternative approach for payment of capital. And so what I'm going to do is talk about that. So if you think about the leaky roof in a hospital, okay, that's a classic example. Every hospital deals with it. And so as I go through this, just kind of keep that in the back of your mind. So the first way you can do that is you can do it historically based. And let me see how I handle these slides. So I do a pros and cons. So let's just slide over to the next slide there, and I can talk about it as we go along. So the historic idea is that you're based on the history. Last year you got $2 million, next year you're going to get $2 million. We're not going to get into the detail. We're just going to give you a set sum of money. You figure out where you're going to spend the money. So that's the idea of paying for it historically. It's well-capitalized facilities then get more money if they've always had more money. There could be, the ones that are out in rural areas and historically have not spent much on capital because they haven't had any money to spend on capital may be disadvantaged. So there is a real problem with the historic approach to capital because it could continue to disadvantage under-resourced organizations, particularly in rural areas and tribal areas like that. And it could also be applied to, if you crossed it another way, to other areas. So maybe, for example, behavioral health organizations have been not historically well capitalized, so it will continue that thread unless something is done differently about it. Next slide. Comparable units. The idea of this is that if finance is appropriate to patient type, so you're going to capitalize acute care organizations one way and transitional care organizations another way, and you're going to capitalize mental health facilities another way. And it can protect like research organizations that have big facilities and a lot of capital expense, but again, it can disadvantage other organizations. And it may reward facilities that have a newer plan. So somebody that just built a brand new hospital, for example, they spent $100 million on it, they're going to keep getting this huge amount of capital, even though they may not need it just because of that's where their money was spent. It could disadvantage facilities that have deferred maintenance, that have put off maintenance because they haven't had the money, and again, can disadvantage rural facilities. Next slide. This is the orientation that you basically capitalize according to the age of the plan. So old hospitals will get more money, and newer hospitals will get less money. The idea being that it's just like a car, if you will. You know, an old car, you're going to have to put more money into maintaining it, so that needs to have more money, and newer ones less. It's a fairly straightforward approach. It's not commonly done, but it certainly could be done in theory. And from a disadvantage is it may incentivize organizations that have made poor facility decisions in the past. Okay, so, you know, they could have put it off and they shouldn't have. Next slide. Patient acuity. This would ensure that if you did it on patient acuity, OHSU would get a lot of capital. It ensures high acuity organizations continue to be well capitalized. It rewards research in urban facilities, but may disadvantage rural and tribal facilities. That sort of keeps the old status quo alive. It keeps it going without sort of thinking about how to reallocate into other areas that have historically been undercapitalized. Next slide. Patient cost of living. So the idea here is that costs more, the cost of living is more in Portland. So we should capitalize higher because to hire contractors and hire various things, it's going to cost more in Portland than it's going to cost in Pendleton, for example. So it maybe takes higher real estate costs into consideration, higher labor costs, but again, it can unreasonably penalize lower cost regions and lead to the continued chronic undercapitalization. You'll notice I refer to this a lot. I have spent a lot of my career running rural hospitals, and you know, they are very commonly undercapitalized, very hard to keep the standards. Licensing has the same standard for rural hospitals as it does for urban, but pulling it together in a rural area compared to doing it in an urban area can be much more challenging. So I tend to kind of allude back to that because I think there is this notion of balanced access and equity in care that has to be thought through. Next slide. So this is a very common, in fact, this is really what's done typically. And that's it's folded into reimbursement. So if you will, the reimbursement is added a little so that the organization can put a little money into its pocket for its capitalization. This is really the way it goes. The legislature that breaks capitalization up is in the bill is really a new way of approaching it because it is not typically how it's done now. The way it's done now, really, whether it, as far as I know, really by any payers in the state of Oregon that I'm aware of, all make payment. And the assumption is that that payment will include dollars that will be set aside and used for subsequent capitalization. And that is part of the reason if you take lower reimbursement areas, for example, in rural areas, they don't have high acuity, so they get lower reimbursement, and then they have less money for their capitalization, and it's what leads to that spiral. The same thing occurs in the tribal areas, in the tribal facilities. But this is the way it is done. Now it takes acuity into account and it permits institutions to make their own capital decisions. They just put their money aside and they figure it out. It relies on history somewhat, very easy managerially. You don't have to have a separate capital approach, separate group of people to analyze capital. It can lead to undercapitalization. Chronic care, rural and tribal facilities that receive lower reimbursement due to lower acuity can get less money. So I think that's the reason that was carved out in the bill. But it is a new approach, and it does require some thought to who's going to get down in the detail. Are we going to let hospitals think through what their capital needs are? Because I can tell you, a capital budget, even for a small hospital, you know, if you sort of go around a hospital and say, okay, what do you guys need? They will come up with a list, and even in the smallest of hospital, it'll be maybe 500 items, maybe 1,000 items that then you have to prioritize and decide, well, what are you going to do this year and what are you not going to do this year? IT is included in that. all of the IT, all of the ventilation, anything associated with a hospital. Next slide. So you could do it zero-based, which is basically we're not going to give you any assumption on capital. It permits the state to adjust their budgets. It ensures state retains all clinical decisions. Okay, now we can decide whether we think that's good or bad, but it means that zero-based means you got to go to the state or go to the payer or go to OHA or whoever it's going to be and say, "Mother, may I?" And you know, I need a new car for you know, lab courier, or I need a new roof, or I need this, or I need that. And the state would make it based on dollar availability. This is a very common approach in other countries with nationalized health systems. Very common approach in Canada. I think it's used in the UK. This is not uncommon, and I expect that's why it found its way into the bill. But it does sort of theoretically have the state getting into a lot of micromanagement of organizations that maybe it should not or does not want to be involved in. Next slide. So the last one is an interesting thing. It harkens back into the past. For those of you that know this idea, the idea is a certificate of need. Okay, and so it used to be that there was this thing called certificate of need. I don't think it occurs, and I don't know if it occurs anywhere right now, but the idea is that the government determines a need. It's not a bad idea necessarily. People are very opposed to it. It was in place for a while, and the idea is that you create a panel, and if somebody wants a new MRI machine in a community and there's already 2 there or already 3 there, that the state or whoever the deciding body is going to say, no, you don't need another one, expand your hours for the existing one. We right now in urban areas have a lot of duplication of capital, a lot of duplication. And so certificate of need could be reinstituted, and it permits the state to validate this need and decide whether you actually need it or you don't need it. But it can be perceived as certainly very heavily overhead from the standpoint of the state decision making. Okay, that's it.
As always, I'm so impressed by how quickly you were able to just summarize so much information for us. I feel like it's so great to have you as our lead here. Now it's time to hear thoughts, reactions, questions that arise from all of that information. To what extent did that pros and cons analysis map onto your understanding, your experience with institutional reimbursement models? Acknowledging that perhaps, as was stated earlier, Cheryl, that this may be a newer way of thinking through reimbursement or may differ from your experience.
Well, for me, thank you so much. So the pieces on the capital budget was something that, at least in this context, I was not familiar with. So I appreciated the overview. The other pieces on the payment models were very familiar, but I also appreciated the way you broke it down. I think that I am still generally in favor, without more information, of a global plus. And that, you know, certain things need to be baked into that to be able to get to the value and the equity that should underlie a lot of our decisions. But thanks again.
Cheryl, yeah.
I agree with Deborah. I'm less familiar with the capital budget, so that was new information to me. And it was a good reminder of all the various ways of being paid. I think my comments are not so much about whether I agree with, you know, any of these different payment approaches, but I wanted to mention that in reading the materials for today, I was looking at the Washington provider reimbursement issue brief, and I noticed that the premise that the author had was it was really about physical health, because in terms of which are the best payers, it's almost exactly the opposite in the behavioral health system. And so I guess what keeps coming back to me is that because of the really pretty big parity issues we have right now in our healthcare system, you know, in terms of compensation differences, payer reimbursement of services that are in behavioral health, there's this whole swath of services that are left out of certain payer reimbursement, and then the non-quantifiable treatment limitations. I think unless we acknowledge and adjust for these differences, we will be trying to fit a square peg into a round hole. And I think in order for us to move forward and do something that will work for the behavioral health part of the system, I think we really have to spend time looking at these differences and doing a comparison contrast. And to that point, I saw it in the last meeting, you know, the action items that I had, my name was on there to do a behavioral health provider type and kind of reimbursement analysis. I just want to let you know I've started that. I'm not completely finished, but because of today's discussion, I think I need to add an extra column on the services that payers pay. I think you would be surprised and maybe shocked at what all is left out in the behavioral health system that providers just don't, I mean, payers don't pay for, and it's subsidized in large part by the federal, state, and county governments. And we will have to figure that out.
Cheryl, I think you're quite right. I mean, I think that from my reading of the tasks that we're about, it's to make steps, concrete steps to remedy that problem. And so, you know, I think that definitely that is assuming that that it's a covered benefit, which I think it is, that then there are going to have to be remedies to make sure that more money goes into that behavioral health world, such that these uncovered things are more adequately reimbursed. So, I mean, I guess that's kind of my thought about it.
Cheryl, I indicated at the beginning that I would be taking a stab at pulling together a straw proposal for the tag to be considering in subsequent meetings. I'm wondering if it might make sense for me to connect with you offline to make sure that I'm capturing some of the nuance that you're pulling together, and we can come forward with both the outline that you're pulling together and also make sure that it's integrated into that straw proposal from the beginning.
Sure, that sounds good.
Great.
And I think that from what I understand from your comments, Laurel, is that we're talking about a matrix. So we're talking about creating something which sort of goes through all of the different details of these providers and sort of plugging the correct approach in each of these. So so that it is sort of taken care of, because there is one question, which is the approach we use. The other question is the amount we put in, you know, the rates that we actually reimburse as well. That's obviously another variable. You could have the correct structure in place, but the compensation could be too low.
It's a great point.
So I just had another observation, or the first observation was incomplete. So I also appreciate the fact that you gave sort of the dichotomy of rural versus urban, right? And really densely populated and really highly resourced versus the alternate. And so because of that, some things that may look great, you know, in Portland Metro won't fit. And so again, I'm always going back to us having some sort of cobbled together assessment of what is going to work and whether that's actually practical. I'm all about equity, especially with the divide of the haves and the have-nots. And so I definitely, on both the payment model and the capitalization, wouldn't want, you know, for example, you know, I think in one of the things you cited around capital was, you know, that one of the cons, you know, if we did something on an individual basis was about, you know, whether or not they had been poorly resourced and squandered their resources in the past. I think at this point, if we're building a new model, that we kind of have to throw that out the window, give them the resources they need to maintain the new capitalization, but that no community should have a subpar health facility. I mean, that should not be an option. And have heavily resourced, really, you know, well staffed and well equipped facilities. That should not be an option. So whatever we do, we have to make sure that it does sort of, you know, raise all ships.
Laurel?
Yeah.
I agree, and I think that's the reason that capital was carved out separately. Because I think there was this notion of equity and access, and the feeling was that if it wasn't carved out separately, there was going to be continuation of the existing inequities.
So far I'm hearing a reiteration of a theme that we heard last time, which was we want to make sure that we are enumerating in a matrix a range of provider types and outlining a range of appropriate models that apply for those types. I'm additionally hearing the importance of highlighting possible differences in needs between rural and urban institutional providers, and the role that capital budget approaches play in ensuring appropriate resources are allocated to specifically the needs of rural institutions. Those are the two main takeaways that I'm hearing so far. Any other thoughts about specific models that Dr. Chadwick enumerated? I'm gonna go, so looking at the agenda. Oh, go ahead, Dwight, yeah.
Yeah, I don't know if this applies to a specific model, but I'm thinking about any model that we develop, we've got to consider provider reimbursement for, again, out-of-state providers and how that's going to play into whatever model we develop. Not only for people who may be residing out of state but covered, but for people who will be covered by this Oregon system that may be traveling out of state, and how we come up with a reimbursement model for services they may receive elsewhere. I also think about how we manage those individuals that are covered by the Oregon system. One of the things that we often ran into when I was in the still working in the behavioral health care system, and I don't think it's unique to behavioral health, but we would have people who would be covered under Medicaid, Oregon's health plan, relocate to another state, but they never got flagged as being residents of another state. So we would be covering their services, or we would be responsible for those services that they received out of state, even though they weren't technically a resident of Oregon any longer, but there was not a way of tracking that. And so I think it's going to be critical that we have a way of managing that process as well. If that makes sense, I hope that
Absolutely. I think you've been really helpful in continuing to highlight the ways that interstate care needs to be considered throughout this entire process.
Yeah,
And there are models for that. This is not an uncommon problem. There are a variety of approaches that organizations take to pay for care out of plan, if you will. Kaiser has that problem, and other payers have that problem as well.
Deborah, did you have something to add?
yeah, no, I was just reflecting on the blast from the past of the certificate of need. While it does seem to be outdated and sometimes can be misused by, those with deep pockets, I think the process for evaluating whether a, equipment or renovations or an expansion is needed is a good and valid process, especially if we're trying to create equity, not simply for providers and facilities, but for the actual patients that they're serving. And I think what comes to mind is, maternal services in one part of the state closing down and forcing those families to try to go a significant distance to get that kind of care, far away from their homes, right? That's something that I think a certificate of need process could have illuminated, that yes, this might be in the best interest of a facility to consolidate their resources, but is it really serving the communities? And if it's not, then what other alternative might be possible, as opposed to just allowing those kinds of shifts in services that aren't really creating equity for patients and communities.
It's a great point, Deborah. Dwight.
Another question, and maybe this is for Chad, but I think as we look at provider reimbursement models, and in rural areas, hospitals in particular have, most have gone to a critical care access type of hospital limited to 25 beds. And then their costs are cost-based reimbursement under Medicare and Medicaid, which has afforded them an ability to stay afloat because they get a much higher reimbursement rate. Is that kind of where you're headed with some of your thinking, Chad, around how we treat these rural hospitals?
Yeah, I mean, I think that they have unique challenges. Certainly the critical care access legislation that really, I mean, that was an afterthought. Originally, they all went on to DRGs, and then all the hospitals were starting to close. I think, though, that it should be observed that the rural hospitals are still nowhere near out of the woods right now, and they're closing by the dozens weekly around the country. And there is a need to significantly beef up their capabilities in order to keep them going. It's a circular equation. I think of sort of like circling the drain. That these hospitals have fewer resources, so they can deliver less care. Then they have fewer resources, and they can deliver less care, and they're just sort of circling the drain. And so the cost-based approach is a good one. But there needs to be somehow more. We need to, instead of them circling the drain, we need to figure out how do we start to bring them back up again. And that really, more than anything, is associated with access to physicians. Because physicians admit people to hospitals, and if there are no certain physician specialties, because the rural area can't get them, then they can't take that patient, and they don't have it. So there are a lot of variables there. And so you might actually think about compensation for physicians in rural areas at a higher level in order to induce people, and we'll be talking later about recruitment and retention, but to induce people to go to those rural areas.
Yeah, and I would totally echo that from the nursing perspective. I have those conversations with the administration often. what will it take to incentivize nurses? Because we're one of the fortunate states that really does not have a nursing shortage. We have a disproportionate shift of where the nurses are concentrated, but we have enough nurses to provide care for all the patients that we have. We just got to figure out what it would take to get them into the communities that have greater need. And right now, there's nothing that's currently doing that. So I would love to be able to have that conversation. I think the other thing too, when we talk about, capitalization and access, we've got to talk about the way a lot of the systems are consolidating facilities, right? That's limiting choice, and it will always create, that disparity between the rural and frontier facilities and the larger system. So I think we need to have a conversation with them in the room to figure out, what it will take to try to figure out how we solve that problem. Because buying up more places and leaving them without resources or patients or providers isn't an option.
I think that conversation would wrap in nicely with the recruitment and retention conversation. Does that sound right to folks? Okay. So I'd like to propose that we shrink our wrap-up agenda item a little bit to give a little bit more time to this conversation. I want to highlight that the legislation provides very overt flexibility with regards to individual provider reimbursement. It feels a bit more prescriptive for institutional providers, although, as I've said several times, it does offer this leeway here for the tag by saying, or using an alternative method that's similarly equitable and cost effective. I'm hearing from you all that the prescriptive nature of this statement that institutional providers shall be paid with global budgets is a bit too narrow, and that you all feel like it needs to capture a broader range of models. Am I reflecting that back to you all accurately?
Yes, I would agree with that.
Yeah, I would agree as well. I think what's missing for me in the global budget is, again, what are we taking into account for that global budget? Once we hand over the pot of money, is there the equity filter? Do we have the data to know what the demographics look like? Are we adjusting for social risk, right? So that we don't have cherry picking of patients in a global budget. So there are a lot of things beyond just that broad term of global budget that I would need some assurances are baked in before I say that would even fit for the larger health systems.
Yeah, I would agree. Although, I think there are sort of ways that you can sort of tinker with it, but I worry about the unintended consequences of a global budget. Here's something to kind of consider. If it does truly become a single payer, that is, it incorporates Medicare, Medicaid, all the private insurance, everything is in, then these hospitals around the state and all the providers around the state are totally beholden to this mechanism and this approach. That's not necessarily bad, but it does mean that if the global budget is wrong and it's not adequate because of acuity or volume or other sort of circumstances, then without sort of some guardrails on this thing, it could lead theoretically to other unintended consequences such as hospital closure and things like that. So, because right now, organizations have an ability to get some payment from some source and another payment from another source, and they make it work out. But if we're really going to a single payer, it is a single payer. And so the power of the state is extraordinary, and that's good because it's what's intended here. But we want to really be careful of unintended consequences. And I worry that just a really simplistic global budget may not last over time.
Yeah, no, I totally agree. I think that there would be oversight and data, and again, metrics to meet equity. I don't think it would be just, you know, a blank check. I think that they would really need to be able to prove the case for where they're going with it, because otherwise, you're right. We may have these unintended consequences. A lot of it can go, you know, off into other areas and not really address the kinds of needs that we're hoping this new plan is going to achieve. So, you know, we don't have a silver bullet for it. And I always say global plus, because we will need some additional types of models built in. But I can certainly be convinced of any of the other models creating a better, at least, foundation. I'm open to that.
Dr. Chadwick.
Sorry. As you're thinking about this and thinking about your straw poll and so forth, I think that, you know, the idea is to create something that takes some of this discussion into consideration, so that if it does end up being a global budget, and there may be an appetite for that, that there is a way to have some guardrails on this, such that if the experience is different in a significant way, that there's a way to kind of protect for that as well. I don't think these are pure. I think that you could even have a hybrid of these things.
Thank you, that's helpful. Are there any, so I want to give us just 4 more minutes here and then we'll wrap up. Is there anything on this list that we definitely, that we definitely don't want to be considering for institutional provider reimbursement?
Fee for service?
Charge question, what?
Fee for service.
Okay.
Doesn't seem to have been particularly useful.
So we're okay potentially with it in the individual reimbursement field, but definitely not for institutional? Or did I misrepresent last meeting's conversation and we're not interested in fee for service for individual?
No, I think that might be appropriate for individual.
Okay. Others?
Yeah, I think for small, for individual providers, you know, the reason it was structured this way is I think that the bearing of risk on behalf of an individual physician out there or an individual behavioral health provider or something may be untenable for them.
That was really helpful, you all. Yeah, Dwight.
I think it's also going to be critical if we look at a fee-for-service reimbursement model for individual providers, especially in the behavioral health field. Who holds that risk is going to be a critical definition, because if we look at, say, going to a capitated or some form of a global budget for a behavioral health system, but you've got fee-for-service providers that are not holding or sharing in that risk, you know, I think is just an issue we need to address. That was a complicating factor for community behavioral health, who, when they initially were capitated, how did we manage that risk for providers outside that capitated system? So
that's helpful. So this was really helpful, everyone. I'm going to suggest, we've already given a list of questions for the CAC. If you could email me if there is anything else that surfaced from this conversation that you'd like to be included for the CAC to consider, that would be great. I want to make sure that we have time to talk about what our next steps are, so that we're all rowing in the same direction here. I feel like I say that a lot with this tag and task force, because it's a critical question. So,
Laurel, can I ask just one really quick question?
Of course.
I know we spend a lot of time pointing out differences between behavioral health and physical health, but I'm also wondering about dental. I know we don't talk about that a lot, and I'm curious as to what the Consumer Advisory Committee thinks about dental. Like, you know, should we be pointing out how dental can be improved? And I honestly, I think probably they're reimbursed fee for service, but I honestly don't know. Maybe you know that, Chad, but I think we probably should add dental and get some feedback from the CAC on how they view dental and, you know, what's important to include. It's just
And the benefit group as well.
Yeah, it's just an area we haven't really mentioned.
It's a great call, Cheryl. Thank you.
And
I
there
think
are some models for prepayment. There are some models for other alternative approaches for dental that are taken. So typically it is fee for service, but certainly you and I can enroll in Delta Dental or any of these plans, and these are insured plans, and they may pay on a fee for service or they may pay in another manner. So
The other thing, as I am constantly having to consider because of COVID, is, you know, sort of pandemic reimbursement. What does that look like for providers who are, you know, going through it? And I can't imagine what it's going to be like in the mental health space, you know, with all the trauma post-COVID for kids as well as adults and providers. But I think that we would be remiss if we didn't start to really think about what that might look like. And that, because that might even mean at some point needing to move providers in agreement around the state to address pandemic or other things, but to consider what that payment model might look like as well.
That's a really good point. And I know that some of my members have had to pay staff hazard pay, you know, because some of the services have to be provided in person. You can't do everything telehealth. So that's a really good point.
Thank you. I pulled together the outline of the meetings that we have been using thus far. Based on our progress, the project team is thinking that both the EBA and the provider tag could benefit from 1 to 2 additional meetings. Does that sound right to you all? Yes, I'm seeing nods from everyone. Dr. Chadwick? Yes, okay. So I added here a meeting 6 with a question mark. Next time around, I think we can think through if we do want 1 to 2, if we want to add a 7th meeting on the calendar, if we want to wait and see. At this juncture, we have our next meeting set to discuss rates. However, we haven't had the opportunity to reflect on that proposal. And so what I would suggest is that I take a stab at drafting some type of straw proposal, perhaps with Dr. Chadwick's eyes and advice and guidance and feedback. And we can spend some time at our upcoming meeting reviewing that matrix that we've been talking about at meeting 4. Does that feel right to you all? Dr. Chadwick, is there anything else you want to add to the whole process conversation?
Yeah, from my standpoint, I think that it's premature to discuss rates until we understand the structure that how the structure is going to apply to all of the different types of providers. And I can even imagine, Laurel, that this may be more than, you know, as we're going through the structure matrix, that this could even be more than 1 meeting, you know, that if you sort of introduce, say, okay, we're going to look at the straw, whatever we're calling the straw draft or whatever, that we may not get through that in one meeting. And I think until we really get sorted out sort of the mechanics of this thing, I don't see how we're going to be able to really discuss the rate question.
That makes a lot of sense. So what I'll do is I'll go ahead and just shift everything down so that meeting 4 is a review of reimbursement model matrix. Deborah?
Yeah, can I also add, in the interest of emergency preparedness, a, you know, consideration for the capitalization, a requirement of a reserve for emergencies for medical equipment or whatever, I mean, if we're talking about capital and
matrix.
things, yeah, I'd like to have that built in, because again, that's sort of purchasing at the margins, just enough so that it wouldn't expire is kind of how we got into some of the dilemma, not all of the dilemma, but some of the dilemma against, you know, having the right equipment. So, you know, I think if we don't address that in some formal way when we're thinking about it, that we could find ourselves in this predicament again.
I'll look at the bill to see how, if at all, it addresses any types of emergency reserve. It's possible that some of that conversation will start with the governance tag, but I hear you that we might want to have a discussion regarding rates and models, and so I'll follow up on that, and potentially we can bake that into the rate setting conversation. Does that sound right? Does that sound okay? Okay.
I think that the notion is good. It could be, the reserve could be required to be held at the facility or the smaller subset level, or it could be a reserve held at the state, and the state controls the purse strings on the reserve. So I think there are various ways you could approach it depending on your philosophy.
I'm so impressed with how quickly we got through, not how quickly, but I'm impressed that we got through all of that content. I'm so grateful to have had that discussion with you all. I'd like to spend the next 10 minutes handing over the time to public testimony. We have Mike and Charlie should both be here. Are you still on the phone? Can we start with Mike?
Yes, I'm here.
Thank you. Can you please state your name for the record? And we're going to set, because we have 10 minutes, we'll set 5 minutes for you and then 5 minutes for Charlie.
That's perfect. Thank you. I'm Mike Huntington, a retired radiation oncologist from Corvallis. I got involved in healthcare reform at the cancer center when I saw patients coming in with advanced cancers. They had waited months, maybe sometimes years, to come in. They were quite afraid of what they thought they had, but they were more afraid of what it might cost. So it was time to get involved. And I am vice chair of Mid-Valley Healthcare Advocates, mainly Benton County, and work with Healthcare for All Oregon, Physicians for National Health Program, and I'm secretary of One Payer States national group. So I would like to just say particularly about provider reimbursement, and that a certain type of fee-for-service would be very appropriate. Our current fee-for-service value-based models are not doing a good job of achieving the quadruple aim, that is, improving patient experience, reducing cost, advancing population health, and improving provider experience. Our current system jeopardizes providers with significant perverse incentives and burdens, both administrative and moral. The ways in which these incentives undermine the egalitarian imperatives are well documented. They create moral injury, burnout with administrative burden, and especially among primary care providers. The concept of time-based fee-for-service reimbursement, we feel, is a better model. And I am speaking for Mid-Valley Healthcare Advocates when I mention this. And I think that TAG Group does have a document on record that is by Stephen Kemble that gives more detail about this concept. It is by Dr. Kemble, a psychiatrist who is former president of Hawaiian Medical Association and currently on the Hawaiian Health Authority. His paper is well referenced, and I think it should be in your hands there. So we encourage not only this TAG group, but all members of the task force and the consumer advisory committees to be aware of it as a guide to a much better reimbursement model than we now have. The conclusion of this is that the fee-for-service payment of independent physicians with time-based reimbursement would be substantially simpler, more objective, and less costly to administer than either plain fee-for-service based on RBS or the evaluation management coding of value-based payments with pay for performance and risk adjustment. Just saying that tells you how much administrative effort there is involved in that. A universal single-payer system that paid hospitals with global budgeting and physician based on reimbursement based on time and expertise, with standardized salaries for employed physicians and time-based payment for independent physicians, would likely achieve a far greater administrative savings and substantially lower total cost than any proposal based on existing Medicare fee setting policies or shifting insurance risk onto doctors and hospitals. I would like to, if I can, share the screen with a few, I think, persuasive slides talking about value-based payment. Is that possible? I think you're muted.
Unfortunately, the settings are such that that's not an option. But what I would like to request is if you could email any type of written materials that you have, even including slides. We can include that as written testimony, and I can make sure that that is made available to the public and to
I think in 1 minute I can summarize those slides.
Yes, please.
That the assumptions implicit with pay for performance is that performance can accurately be ascertained, that individual variation is caused by variation in motivation, that financial incentives add to intrinsic motivation, that hospitals and physicians delivering poor quality care should get fewer resources. And that last statement is borne out by research that shows pay per performance reimbursement is more based on where the physician is and what part of the state or the city he or she is working in, much more related to that than their meeting metrics or producing a better quality of outcome. So those are the comments that you'll see on these slides when I send them.
Dr. Huntington, thank you so much. Charlie Swanson, are you still on?
Yes, I am. So I am Charlie Swanson. I'm an activist with Healthcare for All Oregon Action. I have a lot of comments, but I will mostly keep my comments to the capitalization discussion that went on today. Dr. Chadwick is completely right. The reason that capital budgets were pulled out, mostly for hospitals, but for other purposes as well, was because of equity issues. So I think it's very important for this tag to get maybe an expert from Canada or Scotland, where they do global budgets for hospitals pretty successfully, especially I think Canada, to have them give ideas. Now, you talked about guardrails. I think that they have the global budgets as done in Canada, I think have a lot of the guardrails that you might want to consider to keep it equitable, to keep it so that it doesn't have some of the bad potential outcomes that could occur. They certainly can occur with capital budgets or with global budgets. So another important part is of global budgets is splitting the capital off. And the while Senate Bill 770, as it passed, only has a little bit in it. It does say that the board may wanted to report on a description of regional plan, how the board may enhance, the task force may want to have a description of how the board may enhance regional planning for cost-effective, reasonable capital expenditures that promote regional equity. There's a much expanded version of that. The bill from which 770 was, the original version of 770 before it got modified to become the task force bill, had a description of regional planning boards. And the purpose is to provide open public input into how capital funds and other things should, other things that come up in a region should be dispersed. So it would include notions of how can we get more providers here? What can we suggest to the state system to do? But a large part of that is that we feel that the public needs much more input than they currently do regarding capital expenditures. Hospitals, it's felt too many hospitals make too many decisions based upon, well, where can we make some more money? And that's how they decide whether to close this hospital or open this hospital. And it should be based more on need. So the regional planning boards were intended to be a much more open and involved process than, say, the certificates of need, which sort of did the same thing, but not very well. So I would suggest that it's be really useful to look at and I can send this to you, the original bill 770 that had language describing what the regional planning boards could look like. And certainly that would just be a beginning standpoint. It'd be like, okay, this is something to consider for this tag to consider and say, does this make sense? And you can see, I think, when you read it, that the intent is clearly to allow the public to have appropriate input, including the hospitals, including the hospital administration, to say, what should happen? How should we allocate these resources to best serve the community? And so, it's unclear, it's left ambiguous whether that regional planning board has authority to disperse funds or whether it's just recommendations to the state board. But those could be thought about. Those are things that should be thought about within this tag, I think. So I think I'll leave it at that, and I'll share with you that particular language.
That would be helpful. Yes, please feel free to email any written testimony either via the link on the website, or you can email me and I can forward it along.
Okay.
That's it for this tag meeting. Thank you all so much for this robust discussion and participation. I look forward to seeing you all next week at the full task force meeting.
Thanks, Laurel.
Thanks, everyone.
Bye, everybody. Have a good weekend.
Thank you. Bye-bye.
Thanks.